Welcome to NSG 217 study session 3. We're talking about respiratory system assessment. Introduction. The respiratory system is made up of organs in your body that help you to breathe. Remember that the respiration enables breathing. The goal of breathing is to deliver oxygen to the body and to take away carbon dioxide. In this study session, you will learn about the assessment of the respiratory system. This shall focus specifically on description of the chest landmarks, normal and abnormal breath sounds, assessment of the thorax and lungs. Learning outcomes for study session 3. When you study this session, you should be able to 1. Explain the overview of respiratory assessment. 2. Describe the chest landmarks. 3. Describe 5 abnormalities of the chest wall. 4. Differentiate between normal and abnormal adventitious breath sounds. And lastly, describe how you will carry out respiratory assessment on a client. Overview of respiratory assessment. The assessment of the respiratory system, that is thorax and lungs, is fundamental to determining the client's oxygenation status. Changes in the respiratory system can happen suddenly or gradually. Chest landmarks. Chest landmarks consist of a series of imaginary lines on the chest wall, the ribs, and some spinous processes. The imaginary lines consist of 3 series of lines: the anterior, the lateral, and the posterior. The diagram below illustrates that of chest landmarks. A. The anterior series of lines consists of the following. 1. The mid-sternal line. This is a vertical line that runs through the center of the sternum. 2. The mid-clavicular line. That is right and left. These are vertical lines from the midpoint of the clavicles. Now B. The lateral series of lines consists of 3 lines. 1. Anterior axillary lines, right and left. They are vertical lines from the anterior axillary folds. 2. The mid-axillary line. This is a vertical line from the apex of the axilla. 3. Posterior axillary line. This is a vertical line from the posterior axillary fold. C. The posterior series of lines consists of 1. The vertebral line. This is a vertical line along the spinous processes from C7 to T12. 2. The scapular line, right and left, are vertical lines from inferior angles of the scapulae. Establishing the positions of each rib and specific spinous processes will help you determine the underlying lobes of the lung. Before you can locate the rib anteriorly, you must first identify the angle of Lewis. The angle of Lewis is the junction between the body of the sternum, that is breastbone, and the manubrium, that is upper part of the sternum, to which the clavicle is joined. You will recall that anteriorly, most ribs are attached to the sternum. The upper border of the second rib attaches to the sternum at this manubriosternal junction, that is angle of Lewis. If you want to locate the manubrium, you will first palpate the clavicle and follow its course to where it attaches to the manubrium. Then you will palpate and count distal ribs and intercostal spaces from the second rib. Position stroke lighting stroke draping. Position. Patient should sit upright on the examination table. The patient's hands should remain at their sides. When the back is examined, the patient is usually asked to move their arm forward, hug themselves position, so that the scapulae are not in the way of examining the upper lung field. Lightening. Adjusted so that it is ideal. Draping. The chest should be fully exposed. Exposure time should be minimized. The basic steps of examination. Health history. Number 1, any risk factor for respiratory disease. Number 2, smoking. The pack per year. B, exposure to smoke. And C, history of attempts to quit, methods and results. Number 3, sedentary lifestyle or immobilization. Number 4, age, underage, environmental exposure, and lastly, dust, chemicals, asbestos, and air pollution. Number 5, obesity, and lastly, number 6, family history. Under sputum, consider the amount, the color, presence of blood, that is hemoptysis, the odor, the consistency, and pattern of production. Past health history. Respiratory infections or disease, that is the upper respiratory infection. Also history of trauma, history of previous surgery. Also chronic conditions of other systems. We consider the family health history. Is there tuberculosis, emphysema, lung cancer, allergies, or asthma? Now, inspection. Trachea deviation can suggest tension pneumothorax. Under chest wall deformities, the following are examples of chest deformities. Number 1, kyphosis. This means curvature of the spine anterior-posterior, which is illustrated in the picture below. Number 2, scoliosis. This is curvature of the spine, that is lateral, illustrated in the diagram below. Number 3, barrel chest. In this condition, chest wall increased anterior-posterior. That is, it is normal in children, which is typical of hyperinflation seen in COPD, illustrated in the diagram below. Number 4, pectus excavatum, that is cobbler's chest. Pectus excavatum, also known as sunken or funnel chest, is a congenital chest deformity in which several ribs and the sternum grow abnormally, producing a concave or caved-in appearance in the anterior chest wall. Number 5, pectus carinatum, that is pigeon chest. Pectus carinatum may occur as a solitary abnormality or in association with other genetic disorders or syndrome. This condition causes the sternum to protrude with a narrow depression along the side of the chest. This gives the chest a bowed out appearance, similar to that of a pigeon, as illustrated in the diagram below. Practical steps for respiratory assessment. Tactile fremeters. This is a vibration felt by palpation. Place your open palm against the upper portion of the anterior wall, making sure that the finger do not just touch the chest. Ask the client to repeat the phrase 99 or another resonant phrase while you systematically move your palms over the chest from the central airway to the lungs periphery. The different pictorial assessment of expiration, inspiration, and also percussion of the anterior chest wall and direct percussion of clavicles for disease in lung apex. Auscultation is used to assess breath sounds. Ask the patient to breathe in and out slowly and deeply through the mouth. Begin at the apex of each lung and zigzag downward between intercostal spaces. Listen with the diaphragm portion of the stethoscope. We auscultate for normal breath sounds, note, pitch, intensity, quality, and duration. Normal breath sounds. Bronchial, which is add over the trachea and main stem bronchi. That is second to fourth intercostal spaces, either side of the sternum anteriorly, and third to sixth intercostal space along the vertebrae posteriorly. The sound are described as tubular and ash, also known as tracheal breath sound. Bronchiovesicular. It is aired over the major bronchi below the clavicles in the upper of the chest anteriorly. Bronchiovesical sound aired over the peripheral lung denotes pathology. The sounds are described as medium pitched and continuous throughout inspiration and expiration. Vesicular. It is aired over the peripheral lung, described as soft and low-pitched, best aired on inspiration. Diminished. It is aired with shallow breathing, normal in obese patients with excessive adipose tissue and during pregnancy. Can also indicate an obstructed airway, partial or total lung collapse, or chronic lung disease. The table below shows steps to procedures, actions, and rationales behind each. Summary of study session 3. In this study session, you've learned that 1. The assessment of the respiratory system, that is the thorax and the lung, is fundamental to determining the patient or client's oxygenation status. Number 2, chest landmarks consist of a series of imaginary lines on the chest wall, the ribs, and some spinous processes. The imaginary lines consist of 3 series of lines, that is the anterior, the lateral, and the posterior. Number 3, examples of chest wall diseases are kyphosis, scoliosis, varial chest, pectus excavatum, that is cobbler's chest, pectus carinatum, that is pigeon chest. Thank you. We've come to the end of this study session.